Hello, everyone, and welcome to today's keynote presentation, Acidic Cannabinoids, Inactive Precursors, or Powerful Therapeutics. This webinar is part of the 10th Annual Neuroscience Virtual Conference, and I'm Susie Valdez of LabRoots, and I will be your moderator for today's event. Today's educational web seminar is presented by LabRoots. So let's get started. Before we begin, I want to remind everyone that this event is interactive, and we encourage you to first participate by communicating with other attendees using the new live chat feature during your presentation. You can find that live chat located at the right of your screen. You can also participate by submitting many questions as you want during the presentation. To do so, simply type them into the Ask a Question box and click Send. We'll answer as many questions as we have time for at the end of the presentation. Now, if you have any trouble seeing or hearing this presentation, simply click on the Help Desk button located at the bottom of your screen within the navigation bar or from the lobby. And finally, as a reminder, this presentation is educational and offers free continuing education credits. Click on the Continuing Education Credits link located at the abstract window below the presentation window and follow that process to obtain your credits. Without further ado, I now present our speaker, Dr. Dustin Sulak, the founder and medical director of Integrate Health and co-founder of Healer.com. For a complete biography of our speaker, please visit the Biography tab at the left of your screen. Dustin, welcome. You may now begin your presentation.
Thank you so much. A pleasure to have this opportunity to share this exciting information with your audience today. Thank you for the invitation. So I'm Dustin Sulak. I'm an osteopathic physician, a general practitioner. My practice is focused on integrative medicine, kind of the intelligent combination of conventional and complementary alternative medicine and medical cannabis. I've had great opportunities to learn about cannabis and to teach it and kind of participate in this quickly growing field, and I've been doing this for about 12 years. I'll start with a little story. I practice here in Maine, where we've had somewhat of a different medical cannabis program compared to a lot of states. We have a small population, but literally thousands of different cannabis producers. So the marketplace has always had a lot of artisanal, kind of homemade, small-scale products, and patients are often trying lots of different things, especially earlier in my career. So back in 2013, after Sanjay Gupta aired the first weed documentary and showed Charlotte Figi getting better with CBD, my practice went from mostly adults with PTSD, chronic pain, cancer, things like that, to this very kind of heavy emphasis of pediatric neurology, not just seizures, but other neurologic cases were coming in to see me. And at that time, 2013 or 14, there were no labeling, no lab testing, no real understanding of what was in the different products my patients were using. And the stakes were now higher because I'm treating a lot of pediatrics. And I thought, well, I really need to find out what's in all of these products. So we set up a high performance liquid chromatography machine here in the office, and we started testing the products that people were making or that they were using. Some of them bought from the dispensaries, which had not been in business very long there. And we found some interesting things. And this is what started to clue me in to the acidic cannabinoids. So one quick story is that I had a patient who came in for seizures. She was about 13, very severe seizures. She was having about 20 of them a day. So this is a case where it's very obvious and easy to tell, like, is something working or not working? Mom bought a product from the dispensary that she was told was a CBD product. Nobody knew the potency of it. She started giving it to her daughter, and it started working. Seizures were gone on some days and very few on some other days. They came back for a visit, and I thought, oh, this is great. We just set up this equipment. Let's test. I want to know how many milligrams of CBD this patient is using in this effective treatment. And so we looked inside the product, and we did not see any CBD at all. We also barely saw any THC. What this was a glycerin infusion of cannabis that had a very low level of THCA in it. And I, thought, oh, how could this be right? First of all, it's such a tiny amount of THCA. How could this be affecting her seizures? And no, it's all about CBD, because that's what everybody was thinking at the time. We retested it, and it was certainly THCA. And then A week or two later, I had another patient come in who also found benefits with seizures from the same exact product that was a weak THCA infused glycerite. So that kind of got my attention. Around that same time, there was a tincture that a lot of my patients were using from a caregiver in Western Maine that just seemed way more effective than what other people had been exposed to. You know, I kept getting these rave reviews about this tincture, so of course I wanted to get my hands on it and take a look at what was in it. And it was surprising to me to find that it was half THC and half THCA. So it was only half decarboxylated. We'll talk about what that means. And again, I thought, well, something about this THCA is doing something for people. Maybe it's not an inactive precursor, which is what we had basically been told. There was a little bit of data on it up until that point that it had some therapeutic properties, but not much was known, certainly not by myself. Everyone had considered THCA to be the inactive precursor of THC, and it turns out that is not the case. So I have a whole bunch of data for you today to share. What do we know about the acidic cannabinoids, primarily THCA and CBDA? And then at the end of the presentation, we'll talk about, you know, kind of practical applications, how you can work this into your own lives or that of your clients or patients. And then I'll be happy to take questions. So these are some of the topics that we'll be reviewing today. The acidic versus natural cannabinoids, preclinical studies on the therapeutic effects and mechanisms of action, pharmacokinetic studies, which means how is this stuff absorbed and metabolized in the body, human clinical evidence. We'll review a recent study that made a lot of headlines about the acidic cannabinoids versus COVID-19, and then strategies for clinical use. So to start off, as I mentioned earlier, the acidic cannabinoids are precursors. A lot of people are actually very surprised to learn that the cannabis plant does not make THCA. It does not make THC. It does not make CBD. It actually makes a precursor to these compounds, THCA and CBDA, and then those compounds will convert into their neutral counterparts. Now the A stands for acid, and if you look at this diagram here, you can see, for example, CBGA, which is kind of the primordial cannabinoid, the first one that the plant makes. It gets turned into THCA by an enzyme called THCA synthase, and then with heat, that THCA is decarboxylated. Now the term decarboxylation literally refers to this carboxylic acid group here, this OH and O that I'm circling with my mouse pointer, and then that will leave as carbon dioxide with heat, and you can see that that group is gone. So that's where the term decarboxylation comes from, and THCA is converted into THC. Same thing happens here. CBGA is converted by the plant to CBDA, and then with heat, it can transform into CBD. And I just realized you can't see my mouse pointer, but I think you're probably following along. We're in the middle row of this diagram and on the center of the page here. And then you can see this is the same case for the other cannabinoids. Now, in the bottom right, we have a time temperature graph of how THCA is converted into THC. And you can see that at lower temperatures, like 80 degrees centigrade, that conversion happens very slowly. And at higher temperatures, like 145 centigrade, of course, that conversion happens much more rapidly. And so left at room temperature, slowly you'll get some THCA converting to THC. But a lot of people, when they're making cannabis products, are under the impression that they really want to convert all of that THCA to THC, or all of that CBDA into CBD, and they're actually missing out on a lot of therapeutic properties when they apply high levels of heat and or pressure to these cannabis products. So let's talk about what we know. First of all, THCA is pharmacologically distinct from THC. Most important point about this is that THCA does not seem to act upon the CB1 receptor or the CB2 receptor, which are the main targets of THC in the body. So we expect these compounds to behave very differently. There's no psychoactivity associated with THCA. This has been tested in fairly high doses in monkeys, mice, and dogs. But we do know that THCA modulates the immune system. It has anti-inflammatory properties, neuroprotective, meaning it protects the brain and neurons, and also anti-cancer or anti-neoplastic properties. Some examples are listed on this slide, THCA has been shown to suppress the release of tumor necrosis factor alpha, not via a CB1 or CB2 mechanism of action. THCA has also been shown to scavenge free radicals and to inhibit the growth of cancer in breast and prostate cell lines. There's been models of inflammatory bowel disease in vitro and ex vivo, meaning in vitro would be, kind of like a test tube type of petri dish study. Ex vivo meaning taking animal tissue out of the animal and then studying it that way. Both of those models have demonstrated anti-inflammatory effects of THCA without the biphasic pro-inflammatory effects seen with CBD. Now, let's talk about that for just a second. Biphasic dose-response effects means, and we see this all over cannabis, that in a number of settings, if you kind of start at a very low dose and you start increasing the dose, you'll see better and better results. Like in this model, the inflammation goes down, we increase the dose, the inflammation goes down again. Now, sometimes, in this case with CBD, if you increase the dose enough, you actually get the opposite thing happening. The inflammation starts getting stronger and stronger. And so that was the case with CBD in these inflammatory bowel disease models. It was not the case with THCA. It did not seem to have that biphasic pro-inflammatory effect. Now, there was also one study that came out that was very interesting, suggesting that THCA might be a positive allosteric modulator at the CB1 receptor. So what does that mean? This is something that researchers have been looking for. A positive allosteric modulator of CB1 would make a really good drug. Basically, we make endocannabinoids all throughout our lives, and those endocannabinoids target the CB1 and CB2 receptor for the purpose of keeping us healthy, responding to illness, responding to injury, and bringing the system back into balance. Now, when we use THC, we are directly targeting the CB1 receptor with the THC and maybe kind of overriding our endocannabinoid system, especially if we're using high doses of it. But researchers have been interested in what if there's something we could take that wouldn't directly stimulate CB1, but it would make our endocannabinoid activity at CB1 more effective or a little stronger. That's called a positive allosteric modulator. And it appears that THCA does this. So this might be one of the really interesting mechanisms of action of how, even though it's not directly affecting the cannabinoid receptors, it could be making both our endocannabinoids and other compounds like THC work a little bit better. And this is congruent with my clinical observations. Now, there are some similarities between THC and THCA, and those similarities are outside of the CB1 and CB2 receptors. So all of these receptor targets that you see in the first bullet point, TRPM8, TRPA1, these are cation channels. And there's a lot of overlap in the pharmacology between THC and THCA at these channels, particularly the ones listed on the page here. And some of these are probably therapeutic targets. The ethnobotanical and anecdotal reports of the healing properties of cannabis tea, which are, come out of Jamaica, Morocco, other places that have traditional cannabis use. Well, cannabis tea contains very little THC. Its primary compound that it's delivering is likely THCA in most of these settings. So we have this kind of historical and ethnobotanical evidence that THCA is valued in those cultures and effective. Then also something to consider is that it's almost impossible to get pure THCA. Even at very cold temperatures, there's always going to be at least a tiny amount of THC present. Now, in some cases, the dose of THCA that's effective can be very low. And so we might think, well, yes, THC could be a confounder. This person or the subject or this animal is getting a little THC, but it's such a tiny dose, it probably doesn't make any difference. But I always like to keep an open mind about that, because there have been some studies where ridiculously low doses of THC have had profound physical effects. Now, this is an ultra low dose of THC. This would be low for a human. This is extraordinarily low for a rodent, 0.002 milligrams per kilogram. Yet in 3 different studies, This dose of THC has been shown to protect against a heart attack in mice, protect against liver injury in mice, and also activate long-acting signaling molecules that protect the brain, also in mice. So there's always a potential confounder with THCA, and it's kind of impossible to use THCA without getting little bits of THC. So this is just something that we have to accept. Anytime we talk about treating someone with THCA, we have to know there's a little THC in the background, and that possibly it's actually doing a lot more than we think it is, because tiny doses can do something. Now let's move on to CBD. Unlike this kind of THCA and THC dichotomy where they're actually quite different, CBDA and CBD have a lot more overlap. Their pharmacological properties are similar in a lot of ways. There are some differences which we'll cover, but CBDA has superior bioavailability. It gets absorbed much better into the body, and it's also been shown to be more potent. So not only more bioavailable, but more effective at lower doses. Similar to THCA, it has not been found to act upon the CB1 or the CB2 receptor. But it does share CBD's ability to activate the 5-HT1A serotonin receptor, and it does so much more strongly. Now, this receptor has been shown to be a major part, or the main target of CBD when it's working to suppress nausea and to relieve anxiety. And we suspect that a lot of the benefits that most CBD users experience are actually more likely due to the serotonergic effect. So CBDA mimics that, but it does so even more strongly. CBDA has been shown to be an antagonist at GPR55. This is thought to be one of the anti-epileptic mechanisms of action of CBD, so they likely share those properties. And then, as you can see, some overlapping targets with some of these cation channels. CBDA has also been shown to inhibit tumor necrosis factor alpha. And I think I failed to explain this earlier. TNF-alpha is a major inflammatory signaling molecule in the body that's implicated in a lot of autoimmune and rheumatologic diseases. CBDA has also been shown to inhibit the COX-2 enzyme in particular. So this would be the target of the NSAID drugs, these COX-1 and COX-2 enzymes. And of course, there are some COX-2 specific drugs out there as well. This is an enzyme that metabolizes fatty acid precursors into inflammatory compounds. And compounds that have the salicylic acid moiety in their structure, like aspirin, like the cannabinoids, can be COX inhibitors. Now, if you in vitro study that was published in 2008, you can see that THC, THCA, CBD, and CBDA were all compared to two well-known pharmaceutical agents that also have been shown to inhibit these enzymes, indomethacin and diclofenac. And what you can see, I think the one that really stands out is at the very bottom of the chart, CBDA was a strong inhibitor of the COX-2 enzyme with a potency about the same as diclofenac. So this is another mechanism of action of anti-inflammatory effects. And for people that are trying to use something like CBDA that might be more gentle on the stomach, it seems to be, than, say, taking an Advil or an aspirin, this might support that use case. So now we're going to do a tour of THCA and CBDA in animal models, and we're going to start with acute nausea. And I think you'll find some of this data really interesting and compelling. So first of all, THCA, this is a study from 2013, was shown to have antiemetic or anti-nausea and vomiting effects that are superior to THC without the psychoactive effects. Now, in this animal model of nausea, the dose of THC that was required to decrease, it's actually not vomiting, it's gaping, which is like gagging. What they showed was that THC could start doing that at 0.5 milligrams per kilogram. If you look at the bar graph, you can see, well, 0.5 milligrams per kilogram also worked for THCA, but so did 0.05. So 1/10 of the dose of the required dose of THC worked for THCA. The effect of THCA was reversed by a CB1 antagonist, and so this led the researchers to think, well, maybe it is acting via a CB1 mechanism of action. Now we don't think so. I think if you block the CB1 receptor, most anti-nausea drugs don't work, because blocking that receptor can cause nausea. But the initial finding here was, wow, 1/10 of the dose of THC works, and if you 10x that dose of the THCA, it doesn't make it any stronger. So this tiny, tiny dose works. The researchers then went on that same year to publish a paper on CBDA. And one thing that's important to note, if you look at the bottom of the bar graph, they changed the units. It was milligrams per kilogram on the last slide. Now it's micrograms per kilogram, so 1/1000th of that dose. And you can see here that CBDA started reducing nausea at 0.5 micrograms, a half of a microgram per kilogram, and then at 1 microgram per kilogram, it worked even better, and that was kind of where it plateaued. So these are tiny, tiny doses of CBDA, and also there was no evidence of this biphasic dose-response effect. Let's bring in another chart. This is from an older study, same author, from 2004, looking at the effect of different doses of CBD on the nausea and vomiting model, and you can see if we start where it says 2.5 CBD and then LICL is lithium chloride, that's the thing that's making these rodents nauseous. Well, you can see 2.5 milligrams per kilogram of CBD perform very similarly to the line that's to the left of it, the vehicle, right? So really no effect at 2.5. Then at 5 and 10, you can see that CBD was reducing nausea, but at 25 and 40, CBD was increasing nausea in that lithium chloride model. So here's another example of that biphasic dose-response effect, which did not show up for CBDA. Maybe if they had continued to test higher doses, they would have found it. Maybe not. So moving on to another study by the same group that looked at the same model, lithium chloride-induced conditioned gaping in male rats. And this time they used some different combinations. They used CBD, a combo of CBD and THC, CBDA, THCA, and then a combination of CBDA and THCA. And really interesting findings. So again, here is the CBD graph. This kind of reproduced those earlier results from 2004, where you can see this biphasic effect where CBD works in the sweet spot, but at too high of a dose, it actually makes things worse. Compared to over here, what we're looking at is a study that's exploring the mechanism of action. So how is CBD working? And then also, what's the combined effect of CBD and THC? So you can see on the bar graph on the right, 0.1 milligrams per kilogram of CBD did basically nothing for this test. 0.1 milligrams per kilogram of THC did basically nothing. But when you combine these two ineffective doses of THC and CBD, that you do get a beneficial effect. You can see the bar graph on the CBD plus THC line is a lot lower. Then the researchers said, well, let's look for the mechanism of action. Let's try blocking the serotonin receptor. That's this way, the next line over, the black bar. And you can see blocking serotonin disrupted that synergistic effect. Blocking the CB1 receptor also disrupted that synergistic effect. So there's something happening when CBD and THC are combined, where the CB1 mechanism and the serotonin mechanism are kind of working together to make the result greater than the sum of its parts. Now, looking at the same study, incredibly low dose of CBDA. We're back to milligrams per kilogram, but this is basically 1/10 of a microgram per kilogram. I mean, this is just such a tiny dose of CBDA that was shown to work in the same model. And then moving on, we can see that a very, very tiny dose of THCA also worked. Not as small as CBDA, but it also works. So we're seeing these much more powerful effectiveness in this model of THCA and CBD compared to their neutral counterparts. And then again, looking at the THCA, let's bring in that key there. So you can see they tested to see, well, how is the THCA working? They blocked the CB1 receptor, and that didn't stop it from working. That's this light gray bar, the SR-THCA. All the way to the right, the AM630, they blocked the CB2 receptor. That didn't seem to change anything. But in the middle there, the MK886, they blocked a receptor called PPAR-alpha, and that inhibited the therapeutic effects of THCA. PPAR-alpha is an interesting target to keep in mind. So far, when we've been talking about serotonin or CB1 receptors or these ion receptors, we're all talking about targets that are on the outside of the cell, on the cell membrane. The PPAR targets are actually located inside the cell, deep inside the cell, on the membrane of the nucleus. The nucleus is where all the genetic material is, and these nuclear receptors control the expression of that genetic material. So when you're affecting PPAR-alpha, you're actually changing which genes are turned on and which are turned off, and the subsequent proteins that those genes will code for. So PPAR-alpha seemed to be an important target for THCA. And then the final slide from this study is, well, what happens when we combine these? You can see that the teeny dose of CBDA and a slightly larger dose of THCA that were not significantly effective on their own, when they were combined again, we see that they were effective. And then that combination was able to be disrupted by blocking either the PPAR-alpha receptor, that blocked it quite a bit, or by blocking the serotonin receptor. So again, we're seeing some kind of a synergy between these different mechanisms of action. So the take home from that is that tiny doses of these do a lot in animal models of nausea, and that we are starting to elucidate some of the mechanisms, PPAR-alpha and serotonin. Let's move on to THCA in animal models of liver injury, metabolic disease, and obesity. Here's a study from 2020 that looked at rodent models of chronic liver disease and also obesity-induced liver injury, chemically induced liver injury as well, and studied the effects of THCA. So here's a little background. Main causes of chronic liver disease in humans are viral hepatitis, alcohol, and then what's called non-alcoholic fatty liver disease. And obesity is a major risk factor for that non-alcoholic fatty liver disease. Basically, obesity can cause the liver to become inflamed and fatty, and then when the liver is inflamed and fatty, that makes it the whole situation worse and can lead to type 2 diabetes, high cholesterol and lipids in the blood, hypertension, cardiovascular issues, and people get stuck in this vicious cycle of liver and metabolic dysfunction. And so being able to interrupt that cycle and restore balance to the system is very important, especially with obesity being so prevalent. So here are some of the models that were covered in this study. First, this is a chemically induced liver injury model. And what you can see on the y-axis is fibrosis area. So this is how much scarring was going on in the liver. And you can see the control on the left, the light gray, not much scarring present. When they just add the chemical toxin to the liver, then you can see there's a lot of scarring in the black bar. Then THCA plus the chemical toxin at 20 milligrams per kilogram, fairly high dose. You can see the scarring is reduced some. And at 40 milligrams per kilogram, also the scarring is reduced a little bit more. The researchers also looked at not just the level of scarring, but the expression of genes associated with inflammation. And what you can see over here is that the IL-6 gene, the IL-1B gene, and the tumor necrosis factor alpha gene expressions were all decreased with the treatment of THCA. So there's an anti-inflammatory effect via this, likely this PPAR mechanism, right? The nuclear expression of those genes was decreased. Looking at another model from the same study, the rodents were fed either a controlled diet or a high-fat diet, and then their body weight was measured over time. So you can see on the left, the gray bar is the control diet, and then you can see 15, 18, or 23 weeks of the high-fat diet. Obviously, the rodents became heavier. Looking at the histology of that, you can see in the liver tissue that there's this scarring and this infiltrate of immune cells into the tissue. And you can see it just gets worse and worse from 15 to 23 weeks. And the bar graph on the right shows just how much scarring there is going on in the liver over that time frame. So basically, these animals are given the non-alcoholic fatty liver disease through diet. Now, when treated with the high-fat diet plus THCA, there's a couple interesting things to look at. So the line graph, first, you can see the red line is the high-fat diet plus the THCA. And you can see that after, so these animals were allowed to get fat, they got obese and they got the liver disease, and then they were treated with THCA. And what you see here is their weight dropping. The animals that were on the control diet didn't change their weight, and on the high-fat diet with no THCA didn't change their weight. But what's interesting is that the caloric intake of these animals went down just a little bit, but not that much, but their weight really dropped. So something was changing there in the metabolism. And then you can see here that it was really their fat mass that was dropping. On chart D, you can see the fat mass of the THCA-treated animals went down, but the lean mass, the muscle mass, did not. And this is really desirable in a treatment for obesity and metabolic syndrome. We would really want something that would help us lose weight, but lose that fatty weight and not lose our muscle weight. Same study looked at glucose levels. You can see that even though they didn't return to the level of the control animals, treating with THCA brought down the blood sugar of these rodents. You can also see that the insulin level was much lower in the rodents treated with THCA, so less insulin resistance, more sensitivity to insulin. It actually completely reversed, made their insulin sensitivity even a little bit better than the control animals. And then their triglycerides also came down. So now we're talking about one compound from cannabis that's non-psychoactive, that at least in this animal model has been shown to take obese animals, help them lose weight, lower their blood sugar, lower their insulin, lower their triglycerides, maintain their lean mass, decrease the amount of inflammatory cells that have infiltrated the liver. That's what this slide is showing. High-fat diet, all those brown stains are the inflammatory cells, and then the immune cells that are causing inflammation in the liver. THCA reduces that as well. Reduces macrophages, similar story there. You can see the histology is quite improved with the THCA treatment. And then, as we mentioned, decreasing fibrosis. So this is a high-fat diet plus the THCA. You can see there's a lot less scarring in these animals. So that, now again, these animals were treated with THCA. I mentioned this older study that showed that THC at 0.002 milligrams per kilogram did protect the liver as well. So is that a possible confounder? Of course, that's possible. Could it be that teeny dose of THC in there doing all the work? It could, but I strongly suspect that THCA is doing the heavy lifting in that previous data that I just showed you. Another study looking at THCA. Oh, by the way, if you ever see it labeled like THCA-A, that's pretty much what we're talking about. There's another version of THCA called THCA-B. It appears in very low quantities. Most of what the research is referring to is this THCA-A. But anyways, a little background information from this study. That glitazones are a class of diabetes 2 drugs, and these have been used for decades to target a different PPAR receptor, PPAR gamma. And they work well for diabetes, but their use has decreased a lot because they cause bone loss and osteoporosis. Now, it has been previously shown that THCA is a partial agonist at this PPAR gamma receptor. And so these researchers were working with mice, and they were wondering, does this dose of THCA, 20 milligrams per kilogram, which we know is effective in protecting the liver and all those great things we saw in that previous study, what happened to these rodents when they were treated with a high-fat diet for 12 weeks, followed by 3 weeks of treatment with THCA? What they found was that THCA, even though it stimulates PPAR gamma like those other drugs, probably because it's a partial agonist and not a strong agonist, it did not cause the bone loss or this fatty replacement. It did not increase the fatty tissue of these rodents, which those other drugs can do. It enhanced osteoblastogenesis in the bone marrow cells, which means the bone building cells became stronger and more prevalent. It reduced body weight, it reduced fat mass, it reduced fatty liver in the mice that were fed the high-fat diet. Again, this is just 3 weeks of treatment after 12 weeks of the high-fat diet. They found that it improved glucose tolerance, insulin sensitivity, and insulin profiles in the animals. It induces browning of the white adipose tissue. So this is really a key to health and longevity, and it's getting more and more attention. It has to do with the health of our mitochondria. When when we say do cold bathing or fasting, there's a variety of ways that we can kind of induce this, but basically our white fat is kind of a storage organ. It just stores calories. It's not metabolically active. When we can turn that into beige or brown fat, the color difference is based on the content of mitochondria. So mitochondria are the powerhouses of the cell. It's where we make the energy for the cell. And by having a higher number of mitochondria, they tend to be smaller mitochondria, and they work more efficiently. They don't make as many reactive oxygen species. They also produce more heat. This is really good for metabolism when you can turn the storage tissue of fat into a metabolically active tissue. Very healthy. And then, last one from the study, but for some reason we got a blurry bar graph on the bottom. Basically, what I was just pointing out with this page is that they tried the same treatment on lean mice. And the only thing they saw change with lean mice is that the mice produced more heat, increased thermogenesis, but they didn't lose weight because of it. Whereas the high-fat diet obese mice, they also started producing more heat, but their weight went down, their inflammation went down, and the fatty liver improved. So a safe treatment that seems to selectively act when the system is out of balance and not going to create weight loss in the control mice or the lean mice. Now again, I'm not going to belabor this, but an old study at a fairly low dose, THC, not that old, 2015, but THC at 2 milligrams per kilogram was also able to prevent diet-induced obesity in mice, not necessarily reverse it, but, well, to some extent reverse it, but also prevent it. So that THC could always be a confounder. Let's now move on. I think at the end here, we're going to focus on, gosh, I've got a lot of slides left. I'm going to accelerate a bit, and we might not get to them all. THCA and CBDA in animal models of inflammatory pain. So a little background information, THCA has anti-inflammatory and neuroprotective effects via this PPAR gamma receptor. Preclinical data suggest that these PPAR gamma agonists can protect against arthritis. So these same diabetes drugs could help with severity of disease, inflammatory cells, signaling molecules like cytokines, and then cartilage and bone loss. But the clinical trials, and there have been clinical trials, especially with this drug listed here, that have shown benefit in rheumatoid arthritis patients. Also, CB1 positive allosteric modulators, we talked about this earlier, have been shown to help with pain, yet without causing the cannabinoid effects, which means without getting people high or getting the animals slow or any of the signs of that psychoactivity. So again, that positive allosteric modulator is a very interesting mechanism of action. So these pictures I think are worth seeing. This was a collagen-induced arthritis, so they inject collagen into the joint. You can see the mouse foot, right? There's the control on the left. CIA is collagen-induced arthritis. You can see how much swelling there is in the foot. Then with the collagen-induced arthritis treated with THCA, pretty much no swelling, maybe just a slight amount. And then that effect was able to be blocked by blocking the PPAR gamma receptor and also by blocking the CB1 receptor. So maybe dual mechanisms of action, and maybe that tiny bit of THC was also helping. But really profound anti-inflammatory results with THCA in this study. And the authors measured lower levels of these inflammatory molecules, IL-10, IL-17, and the type 2 collagen. Sorry, the images got a little translated, and I apologize for that. Another study looking at inflammation and pain. This was carrageenan-induced hyperalgesia and swelling in a rodent model of inflammatory pain. They were given various doses of CBDA, CBD, and THC, either 60 minutes before or after the injection of carrageenan into the paw, and it's that injection that causes the inflammation. So again, you can see over in the top left, chart A, you can see that 10 micrograms, we're back in micrograms now, 10 micrograms of CBDA reduced the excessive pain significantly, and interestingly, there was a biphasic effect here. 1,000 micrograms did not. This was not statistically significant. So the lower dose worked, the higher dose, both of them are low, but the ultra low dose worked and the fairly low dose did nothing. And then you can see similar results when injected afterwards. And both of these were after. So the carrageenan had already been injected, and then the no, I apologize. On the left, we're looking at pre-treatment. So treating the animals with CBDA first, then injecting the carrageenan, and then measuring their pain either 180 minutes after the injection or 360. So you can see somewhat of a long-lasting effect there for pain, a very minor effect in the swelling. After the treatment, the results were less profound. That's the chart on the right. And then, yeah, I apologize that this kind of zoomed in somehow, so I'm not going to be able to fully go through this slide. But I think basically the take home was that very tiny doses of CBDA that were ineffective and relatively low doses of THC that were ineffective, when combined together, there was a synergistic effect. So this was a study showing that CBDA and THC worked well together for pain and inflammation, and that's something that I've seen clinically as well. Let's talk a little bit about absorption and distribution. One study looked at these compounds in a model of epilepsy, and the big question was, are the acidic cannabinoids even getting into the brain? And another slide that didn't work, but the answer is barely at all. They do get in there, but much lower, what we would call the blood-brain ratio is much lower with these compounds than their neutral counterparts. So CBDA can cross the blood-brain barrier, but doesn't do it nearly as well as CBD. However, once it is in the brain, it seems to work more effectively. It has stronger potency or efficacy. Another example from this study, CBDA, and this is just one seizure model in rodents, but it had an anticonvulsant effect at 10 and 30 milligrams per kilogram. That's the dose they gave the animal, which was a lot lower than the same model for CBD, 100 milligrams per kilogram. So again, think of 1/10 of the dose of CBDA is working, even though barely any of it is getting into the brain. So it seems to be a powerful agent. The little bit that does get into the brain seems to do a lot. So that's part of the pharmacokinetics. Gets absorbed well into the blood, but not great into the brain. And then this was a transdermal. I thought it was interesting to point out that these acidic cannabinoids do get absorbed well through the skin, at least in dogs. So this was a fairly low dose for dogs of mostly CBDA, a little bit of THCA, THC, and then also a fair amount of CBD. So you can see the composition of the ointment here. And that was rubbed into the ears of 6 beagles twice daily for 2 weeks. And you can see that they had much higher blood levels of CBDA than they did CBD. So transdermally, CBDA seems to be better absorbed than CBD as well. And it also had an anti-inflammatory effect in these dogs. Moving on, this was a mouse study that looked at how well these different cannabinoid compounds are absorbed either by themselves or in combination with each other. Now, when we take fat-soluble compounds, like say like a vitamin A and vitamin E, they're both fat-soluble. If you take them at the same time, they're going to compete for absorption. And so you're not going to get full absorption. You would actually do better to space them out a little bit and take them with fatty foods so that you can more fully absorb each one. That's expected to be the case and is the case with the neutral cannabinoids. And so but something stood out different here. What I'll show you is these acidic cannabinoids, when given, this is CBDVA and CBGA, so we haven't talked much about these yet, but you can see that when given as a pure compound, that's the dotted line, their absorption was much better than when given in a compound in combination with a bunch of their kind of brothers and sisters from the cannabis plant. Same thing for CBGA and really all the other acidic cannabinoids they tested except CBDA. For some reason, when CBDA was given in an extract of cannabis with a bunch of other cannabinoid compounds, it got absorbed way better than it did by itself. It was not the case for CBD. The one that really stood out was CBDA. So why does it get absorbed so much better in the context of a broad spectrum of cannabinoid compounds? And these researchers figured out the answer, which, how are we going to do this? Sorry, the slide got messed up again. I really apologize for that. The answer is quite profound, and that is that we have these efflux pumps in our intestine. So basically, when things get absorbed into the intestine, from the lumen, the inside of the intestine, into the bloodstream, some of them are actually kicked back out into the intestine. We have these pumps that will kick things out. And that happens for CBDA. It happens for a lot of compounds. These researchers discovered that both THC and CBG were able to inhibit that efflux effect on CBDA, meaning that when CBDA is taken with very small amounts of CBG or THC, its absorption is phenomenally higher, much, much higher when taken with those two compounds, something to remember. I'm going to skip over a few things here, but just to show you some of the absorbability of these compounds in humans, we do have some human data that looked at medication. These were 9 patients with medication overuse headache that were taking 2 different compounds. You can see them at the top of the slide. One was a cannabis oil, one was a cannabis decoction, which is like a tea, and they both had very low potencies, contained some CBDA and some THCA, and they were kind of like, partially decarboxylated preparations. But what you can see in both of these charts is that this orange line is standing out. This is the blood concentration over time. And what you'll see is that way more THCA was absorbed than THC. And also, the THC line is in gray. It's so low to the bottom, it's hard to perceive there. There were the same results with CBDA, even more impressive. Look at the absorption of CBDA compared to CBD. Now, if you look at the oil, for example, you can see there were roughly similar levels of CBDA and CBD. There was more CBDA, but not even double the amount. And look at how much more was absorbed. And when you crunch the numbers, it turns out that in tea or decoction, THCA was absorbed 50 times better than THC, and CBDA was absorbed about 5 times better than CBD. Also pretty impressive results in the oil as well. 32 times better absorption of THCA and 11 times better absorption of CBDA. So theoretically, we need a lot less of these compounds when used therapeutically. And we have another pharmacokinetic study in humans, but because of time, I'm going to skip over that and just go really quickly to the COVID data. So this made headlines. And what these researchers basically did was use a technique to see, basically throw a bunch of compounds at the spike protein and see what binds the spike protein. And what they found was that from cannabis, the 3 compounds that bound the spike protein the best were the CBGA, the THCA, and the CBDA. These really bound on to the spike protein. Now, the researchers weren't able to continue working with THCA, so they continued with CBGA and CBDA, but we would expect the results to be similar. They modeled it out and they showed, yes, we understand where these molecules are likely binding to the spike protein, and then they tested it in live cells in vitro, and then they also tested it in animals to see if this is binding the spike protein, does it actually prevent the virus from infecting the cell? And the answer was a very strong yes. You can see that it got a little cut off, but I think you can see it here. As the dose of both CBDA and CBGA went up, its ability to prevent infection or to neutralize the infection ended up going up. And these were at, I would say, potentially clinically relevant concentrations. maybe a little on the high side of what we could achieve in blood or tissue, but not far outside the range. And I discussed that in detail on a previous webinar, which is in the Healer training program. So you can see they also tested it with 3 different varieties, 3 different variations of the COVID or the SARS-CoV-2 virus, and it was effective at all of them. So I'm just going to wrap it up now, how to implement this into your life. I think you get the point. These are powerful compounds. They're not inactive precursors. They're highly bioavailable, highly complementary, and in some cases synergistic with the neutral cannabinoids. So how do I recommend this to my patients? Cannabis tea is a very effective way to do this. Take a little bud, throw it in your cup, pour some boiling water over it, let it steep and drink it, or throw it in your coffee or your tea. It'll change the flavor a little bit, but it's a nice way to get these. Now, I want to warn you that if you use something fatty in your tea, like a creamer or whole milk or something like that, then you're going to be increasing the solubility of THC. If you just use water, you would have to be very sensitive to THC or have a very, very big cup of tea in order to get enough THC to actually have a psychoactive effect or an impairing effect. But if you add that coffee creamer, that might change the story. The tea water at 212 degrees does not cause much decarboxylation. And while THC has low solubility in water, THCA has higher solubility. So that's mostly what you're going to be getting. You can also just make a cold ethanol tincture out of raw cannabis flower, and it's going to be mostly THCA. And then if you don't want to take the time to do that, literally just take a little bud and eat it. Depending on the variety that you're using, that'll be a pretty good dose of THCA and or CBDA. Now, what I've seen clinically is that when people are using the raw cannabinoids, they don't get pain relief like on day 1, which sometimes they do with THC and sometimes even with CBD. I think that the effects tend to build over time, and that's probably because the mechanism of action is more of an anti-inflammatory mechanism than an analgesic mechanism. However, the antiemetic, the anti-nausea effects can be super rapid. I've had people that have not responded to smoked cannabis take a little bit of a cannabis flower, chew it a couple times and stick it in their cheek, let it mix with their saliva, and 5 minutes later the nausea is gone. So these, both THCA and CBDA, are very good anti-nausea agents in my experience. CBDA tends to have higher potency than CBD. And at Healer, my company, we produce products. Our CBD product has some CBDA in it. It's about 15% CBDA. And then we have a CBDA dominant product. I was just looking at the comments that we got recently, and a lot of our users find that they're able to use like a quarter to a half of the dose if they use the CBDA product. They find that CBDA gives them the benefits of CBD, but at a much lower dose. And then just final take-home point, THC and THCA are quite different pharmacologically. They have some overlap, but it's not that clinically significant, whereas CBD and CBDA are very similar, just the bioavailability and the potency is different. And that is the end of my presentation. I invite you all to check out my work on healer.com. We have a whole lot of free, it's totally complimentary patient education there to help anyone get good results with cannabis. We also have a paid training program. And then if you're interested in our CBDA or other hemp products, you can find those on healercbd.com. And that is the end of my presentation. Thank you so much.
And thank you, Dustin, for that informative presentation. And we will now start the live Q&A portion of this webinar. If you have any questions, this is a good time to ask. Please just click on that Ask a Question box located on the far left of your screen. So let's get started. We already have some great questions coming in.
Great.
Our first question from an audience member is the THCA plus CBDA synergistic effect on nausea biphasic?
Biphasic, yes. So great question. It does not appear to be, even though perhaps if those researchers had broadened the range of doses that they tested, they would have seen that. But in the data that we have, no, it does not seem to be biphasic. Now, what I didn't mention is that clinically, I have observed, especially THCA, to sometimes have biphasic effects. There tends to be a sweet spot with that drug, and not necessarily for nausea, but for other conditions. CBDA, I haven't observed that very much.
Thank you so much. Now, Justin, how do you decide CBD or THCA for seizures?
Great question. So, right, we talked about how THCA can work for seizures. When I'm seeing somebody with seizures who's new to cannabis, I'm kind of thinking about it in three different ways. You know, what should be my first treatment approach? THC, which is always a consideration, CBD, or THCA. And the way I decide that is that THC will often produce side benefits for comorbidities, like if somebody can't sleep, if somebody's in pain, if somebody has a lot of nausea or other GI effects going on, I'll lean towards the THC. CBD tends to be a little harder on the gut, so if there's GI things, I'll lean away from CBD, but it tends to be really good for helping cognition. So in people that have developmental delay or trouble thinking, CBD is often my go-to. THCA, when I'm using it to treat seizures, seems to have less of these side effects, less side benefits, less negative side effects. But one of the ways that it really shines is that usually it's effective in very low doses when it is effective. So it ends up becoming a much more cost-effective treatment. So for someone that's worried about cost or doesn't have a lot of financial resources, as many of you probably know, treating seizures with CBD can be extremely expensive. THCA is often effective in these tiny, tiny doses. It can be a little harder to find a good consistent THCA formula. And then, as I mentioned before, it can be finicky. Sometimes we'll start at a low dose, we'll titrate up and we'll see some benefit. And then as we continue to titrate, the benefit goes away and we have to actually reduce the dose again to regain that anti-epileptic effect.
Thank you so much. We have time for a few more questions. Any thoughts on the role of terpenes in the described effect of THCA?
I think that when people, like clinically, when we're taking, cannabis tea or eating the raw bud, yes, we are, or even products that are produced with great care to maintain the acidic state of these cannabinoids, those products are likely to have more of the terpenes in them, just because a lot of the terpenes evaporate when the decarboxylation happens, or typically that's how it goes. So I would expect people that are using THCA to get more exposure to the terpenes. However, in a lot of these studies, these were purified compounds. So I think a lot of the data that I showed you today was not confounded by terpenes, even though I think the terpenes are very therapeutic at low doses. So it's a very good question.
Thank you so much. Now, our next question, I would like to understand which is better for treatment, CBDA and THCA or CBD and THC. And the second part of this is, in the future, will we use more of that acid cannabinoids?
So, I mean, the answer is all of the above, right? One of our most successful formulas that Healer produces in the medical market here in Maine and Maryland is called Healer Balance, which contains equal proportions of CBDA, THCA, CBD, and THC. I think you saw that CBDA can outshine CBD in some cases. However, it doesn't necessarily get into the brain well, even though it might be more potent in the brain. And so there's probably some rationale for including everything here. You saw examples of THC and CBDA working really well together for pain and inflammation, examples of THC and THCA working together. So I think it's all of the above. What I would really like to emphasize for people that are making cannabis products is do not fully decarboxylate. Even if you leave 10 or 15% of that acidic form, you're likely going to have a more broadly effective and more potent product that will also be more cost effective.
Thank you so much. Now, are there reliable commercial formulations of THCA?
It's hard to do. For years, we instructed the parents of our seizure patients to kind of do an ethanol extract, lay it out on a thin tray, and then blow a fan over it so that you can evaporate the ethanol. I mean, it's hard to do at low heat. Healer developed an extraction method that actually part of it is patented that allows us to do this with very low levels of, well, it's actually very cold and also very low pressure And so we take our time. We pay special attention to maintaining that THCA. So yes, we have THCA formulas through the Healer brand that's only available in Maine and Maryland. And then I think other markets are starting to, offer THCA products, but it's early. It's absolutely early.
Thank you so much. And I want to thank our audience for these great questions. We have time for 2 more questions. Is this helpful for essential tremors? How do you take it?
Essential tremors, it's challenging to treat. I haven't had a lot of great results with essential tremors. People come in with that problem and they end up getting better sleep and other aspects of their life is better when we treat them. But the tremor itself doesn't always respond to cannabis. But still, I would say the best success I've had with essential tremors is with THC. And sometimes when oral THC doesn't work, I would lean towards the inhaled THC, which can be helpful.
Thank you so much. We have time for 1 more question. Great questions coming in. How can CBD users get started with CBDA?
Yeah, so they're very compatible. So depending on if you feel like you're getting good results from CBD, I would encourage you to add a little CBDA, like say 5 or 10 milligrams, and see if you notice anything more effective happening, and then try staying on that CBDA and discontinuing the CBD. I have a lot of people that are able to completely switch over from CBD to CBDA. They don't feel like they're missing anything from the CBD. They're getting better results, saving money. So it's something that I encourage a lot of CBD users to try.
Dustin, I want to thank you for your time today and for your important research. Before we go, do you have any quick closing remarks for our audience?
No. I've said enough. Thank you so much for your time and attention. We packed a lot into this hour. I hope that I've gotten you excited about the acidic cannabinoids. Test them out in your own life. Send us an email. Let us know what you're noticing. These are powerful compounds.
Absolutely. And before we go, I want to thank our audience for joining us today and for their interesting questions. Questions we did not have time to answer today, and those submitted during the on-demand period will be addressed by our speaker via the contact information you provided at the time of your registration. And this webcast can be viewed on demand for 2 years till March 2024. LabRoots will alert you via email when it's available for replay. We encourage you to share that email with your colleagues who may have missed today's live event. Until next time, take care, everyone. Be safe. Bye-bye.
Thank you.